The message here is that you can also prevent type 2 diabetes in the society, not just in science.
Welcome to the THL podcast. We're going to be talking about the Finnish Stop Diabetes study, and we have here two guests today. We have Penny Breeze from the University of Sheffield, and then Jussi Pihlajamäki from the University of Eastern Finland. And the first question is, what do you think, can this model be cost effective?
So this, I think, is the key question. We've a lot of discussion that in the end, these things to be implemented in the society and to be important also for the policymakers, it has to be cost effective.
We've done a lot of work on cost effectiveness in the UK setting for diabetes prevention interventions. And I think there's definitely a strong indication that there's potential for these types of interventions to be cost effective and even potentially cost saving for healthcare systems. Especially in this case where the interventions are sort of working at different levels and minimizing the cost side by providing the interventions digitally and at a population-based intervention style. Yeah.
And the second question is, what are the limitations of these kinds of health interventions?
Yeah, this is the other critical thing, which was actually we thought about the lot when we were planning the whole thing, and also based on the previous scientific and societal experience. So the big limitations usually in this kind of approaches are that we cannot reach the people we should reach. So the people who are kind of more at risk tend not to be the most active participants. The other potential limitations are that people are not adhering to what we are providing them with. So I would say that in this particular case, in the Stop Diabetes intervention, we were very good actually reaching individuals at risk, with a high percentage of at-risk individuals reached. The limitations that come out, not really surprising, but that do come out there, is that it's still very hard to provide all the people at risk, and even those willing to participate, to provide them with efficient interventions. And especially the one limitation is that people would like to have something which is personalized. And in this case, we are not really exactly there. With the data we have, we can now, in the future, provide more personalized interventions. But in the Stop Diabetes study, it was not really fully personalized.
Yeah, I think I agree. And I think the key question is always who are the people who are most likely to benefit from the intervention, not just who are the most at risk. And the more studies like this that can sort of look in depth and at the types of people who are benefiting most will be really useful. Going back to the cost effectiveness side, in finding the people who should be targeted to receive these types of interventions and identify alternatives for people who don't seem to respond very well.
So can I just add here, because I think this is a very important topic. So we tend to think that the thing we are actually stratifying people to target groups is based on the risk. But Penny is here bringing up the very important aspect, which is that we should also be able to stratify people based on who benefits, or who actually picks up whatever action it is we are providing them with. So it's very important that we actually can go towards the stratified approaches. Maybe not exactly personalized or individualized, but at least to stratified to target groups.
Right. And so the final question, what needs to be taken in account so that health interventions do not increase inequalities in health?
This is also, I think, it's a big question in all Western countries, not to mention the whole other part of the world. So there are big inequalities in health, and that also reflects very much to who are picking up this type of intervention. So that's a huge problem. And so we have been looking at this too. So it seems to be so that these kind of digital tools we are currently using, there is a risk that there is something like 10 to 20% of people who actually cannot pick up the digital applications. The other part is that when you think about some group coaching, which was part of the Stop Diabetes too, is that it's always the same thing. The men are less willing to participate. Lower social economic class is more active in these kind of approaches. So I think the basic thing is that we cannot expect that one size fits all. We need to have some targeted approaches really to reach these less likely to participate individuals as a site for the general population approach.
It was really interesting at the presentations to see how recruitment differs by socioeconomic group into the screening program. I think the knowledge gathered from that has been iterated several times that will be really useful and really powerful for the future to help target interventions to increase adoption and participation in some groups.
Can I have a final word here?
Sure, absolutely.
So the important final message is here that type 2 diabetes can be prevented. So this is something that we basically, from the scientific point of view, we know for 20 or 30 years. So with a healthy lifestyle, you can prevent type 2 diabetes. I think the message here is that you can also prevent type 2 diabetes in the society, not just in science. But we just have to take in consideration these things we have been discussing now.
Okay. Well, thank you for our listeners and thank you for our guests, and we'll see you next time.
Thank you.
Thank you.